Hi, I'm Amerigo Rossi, Assistant Professor at Long Island University, Brooklyn, and President-elect of the Greater New York chapter of ACSM, and I'm here to introduce Thomas Hammett, DPT. Thomas is the Director of Clinical Services for Pinnacle Medical Wellness, where he helps to manage the daily operations of lifestyle medicine-focused clinics for multiple medical groups and provides consulting and training for clinicians and leaders in adopting lifestyle medicine practice. Prior to this position, Thomas worked as an orthopedic and lifestyle medicine physical therapist. He is a graduate of the Doctor of Physical Therapy program at Duke University's School of Medicine. Thomas has over 10 years of work experience in facilitating a wide variety of groups around values-based behavior change and teamwork. Since receiving his DPT, Thomas has received an advanced board certification as a certified lifestyle medicine professional by the American College of Lifestyle Medicine. To wrap up his bio, Thomas wanted to include a personal quote about his why. "We have a distinct duty to fulfill the call to action to change medicine. The only way that we can change our situation is to stand up, visualize a better system together, and endeavor to make continuous improvement with our peers. This is an opportunity that I wake up every day hungry to pursue." Without further ado, I'd like to introduce Thomas Hammett, DPT.
Hello, everyone, and thank you for sticking with us here at the ACSM Greater New York Regional Chapter Conference. This presentation is a case for reading physical therapists and exercise specialists on the same team. My name is Thomas Hammett. I'm a physical therapist and certified lifestyle medicine professional by the American College of Lifestyle Medicine. I attended physical therapy school at Duke University and currently work for a company called Pinnacle Medical Wellness, which runs lifestyle medicine programs in the greater Seattle area. A little introduction to myself beyond just my professional life. I, in particular, love hiking and climbing mountains, and this is the picture of me at the top of a summit of Mount Adams here in the state of Washington. So it's my absolute pleasure to be here with you guys today. I understand that many of you might be students who are thinking about making a career choice into particularly exercise or physical therapy and trying to decide which pathway to go. I myself was in those shoes not too long ago, and I'm just looking forward to talking to you guys a little bit about my profession and how I think we as physical therapists can work a little bit better with fitness professionals to fill what I think is a pretty big void in medicine. For disclosures, I have no actual or potential conflicts of interest in relation to this program or presentation. I'm going to give you some objectives up front. I'd like to start by providing a brief history of the physical therapy profession, then go on to describing the physical therapist as it pertains to preventive medicine. I'm going to propose an intuitive medical pathway to prescribed exercise by proposing a shift in the physical therapist and exercise specialist relationship. And then I'll try highlighting the current challenges within this referral pathway and the signs that a physical therapist might be a good candidate for collaboration in the fitness world. So let's get started. So I want to start with challenging your thoughts about what you might believe a physical therapist to be. So physical therapists are often looked at as people who help fix pain through potentially, as this woman is doing, a use of therapeutic modalities that are a little bit more passive. We might often be associated as being similar to massage therapists or people that use our hands to help fix people. What I want to do is start with giving you guys a history of how physical therapy started here in the United States. So physical therapy as a profession developed and grew as a needed service for working with two primary groups. The first was previously healthy people, particularly men, who were wounded during wartime. The second group of people was polio patients who had a very specific diagnosis, neurological diagnosis that we developed neurological techniques that we still use many of today. And much of our history is actually dictated as how we've developed as a profession as well. So we started with this group of people that were healthy that we wanted to rehabilitate to as close to their previous state as possible, or back to their previous state, which was pretty realistic for most soldiers who were fighting in World War II. For polio patients, we were trying to help them deal with that particular diagnosis as best as we possibly could, depending on their specific circumstance, which is really very much the defining factor of how neuro-PT is still done today. Over time, PT has evolved. We now work with individuals throughout the lifespan with a wide array of musculoskeletal, neuromuscular, and cardiovascular diagnoses. So people with bone, joint, and muscle issues, people with issues to the nervous system, and then heart, lung, and otherwise cardiovascular diagnoses. Physical therapists are found in many hospital settings as well as outpatient settings. But orthopedic physical therapists are what I'm probably going to spend most of my time directing my energy towards today. It's the largest subspecialty of physical therapy, and orthopedic physical therapists specialize primarily to deal with biomechanical or movement-related dysfunction, and usually as it pertains to pain. So people come and see us when they are experiencing pain, expecting to have some kind of pain alleviation and return to their previous level of function as it pertains to the reason that they present to us. In most states in the United States right now, physical therapists are direct access providers, which means that you don't need a referral from your physician to come and see a physical therapist. Physical therapists can see people right off the streets, and part of us being direct access providers is that we've learned a lot of skills for triaging and screening for red flags, just to make sure that people are safe to come and see us with regards to the issues that they show up to us for. Lastly, we utilize techniques including therapeutic exercise, manual therapy, neuromuscular reeducation, and functional training. And this is true throughout any of the settings that physical therapists work in, that we're prescribing exercise, using hands-on treatments, retraining movement, and providing cueing for neuromuscular reeducation, and then doing functional training to help people get back to the function that they were in before. So as we've developed, and again, I'm going to focus particularly on that group of therapists that developed as if they were treating that previously healthy wartime soldier, previously healthy athlete, previously healthy someone. So the traditional orthopedic physical therapy process was developed for those previously healthy people. And as we as physical therapists do our evaluations, we assume that there was some kind of event that led to a broken structure or some kind of anatomic dysfunction that eventually led to pain. These events can be many over a long period of time or something acute, but typically we believe that there is some kind of movement-related event that caused a broken structure that led to pain. And as a result, it sets the stage for a plan of care for us to search for broken structures. So step one on your PT evaluation, if you've ever been to a physical therapist, what they'll spend a lot of time doing is testing to see if they can find a structure that they would consider to be broken. After that's been done, we'll provide some education and say, our goal is to help you fix or support that broken structure and get you back to whatever level of function you wanted to be at before. Essentially saying that we will help you fix your pain, and then we'll send you back on your way to the normal life that you were living before this. This model that physical therapists have been practicing in frequently works for resolving pain in healthy, acutely injured individuals. This is what we call treating the body part, or a biomedical process, if any of you are familiar with that term. So the question I have for you guys is, how often do you think patients present to us in this nice and tidy manner? I'll give you a second to think about that. And the answer, frankly, is that people almost never present to us previously healthy, living perfect lifestyles that would not have predisposed them to that injury in the first place. Most people are not presenting to us previously healthy, is what I'm saying. And when we look at people as just the result of an acute event, of a broken structure, or a flare-up of something that's even older potentially, we miss all the things that happen in the background that might be leading to that acute event. Generally, most of us are living in some kind of state where we're putting our body in risk for chronic physical breakdown. And there are things that we can't control, such as age and genetics. But for most people, it's not those things that are predisposing us to the chronic physical breakdown that I'm talking about. It's a number of different other things that exist in the background that affect us on a day-to-day basis. Potentially our work and environmental hazards and the way that we treat our body when we're at work or at home. Likely inactivity and weakness and being deconditioned lead to a greater risk of injury and tissue breakdown, and a greater likelihood that an acute event like say a rotator cuff tear or an ACL tear might happen. Sleep deprivation and fatigue for both active and inactive people is more likely to lead to chronic physical breakdown, inflammation, lack of recovery that leads to those acute events. Certainly the same applies for nutrition and eating behaviors. Any other general inflammation and metabolic dysfunction that might be caused by those other factors that I just mentioned, but maybe related to something else, can cause chronic physical breakdown. And then stress, relationships, and other psychosocial beliefs might be contributing to the entire picture of this chronic physical breakdown that happens in the background. And again, if we just look at people as an acute event, if we just look at people as a broken body part, we miss all of these things in the background that truly lead people to be more prone to the injury that they present to us for in the first place. If we look at people as an acute event, we're not doing enough to take in the big picture of what might help our patients in the long run. And if any of you are aspiring to be physical therapists someday, my plea to you is please do not look at people as broken body parts. Do not look at people as rotator cuff tears. Think about the entire picture of what might be leading someone to present to you in that day, and take that as part of the picture for why they might be seeing you. So there's this other part of the picture that I'm talking about here, which is chronic metabolic disease and that chronic breakdown that happens in the background. So I'm going to give you some statistics about chronic metabolic disease in the United States. It's estimated that about 12% of Americans are metabolically healthy. That means that they have no risk factors that we would call to be those metabolic syndrome risk factors. So about 88% of us are in some state of metabolic dysfunction. 6 in 10 Americans has at least one diagnosed or undiagnosed chronic disease. Chronic diseases might include cardiovascular disease, type 2 diabetes, lung disease, and so on and so forth. By 2030, about 50% of Americans will have a diagnosis of prediabetes or type 2 diabetes, leading to permanent changes in the pancreas and vasculature. Again, those things that lead to definite connections of muscle and tissue breakdown. And chronic diseases in most cases are preventable and much more challenging to reverse once the onset has occurred. So chronic disease leads to worse health and quality of life outcomes in every possible way. What we know is that there's a number of lifestyle factors, and this is where some of my training in the American College of Lifestyle Medicine comes in. I would recommend for you guys, because in the scope of the time that I have with you today, there's probably not enough time to dive deeply into all of these factors, though I did mention them briefly in the previous slides. But lifestyle factors like healthful eating, increasing physical activity, strategies to manage stress, paying attention to those important relationships in your life, focusing on getting good night's sleeps on a consistent basis, and then avoiding risky substances like drugs, alcohol, and tobacco are ways that we can prevent the statistics that you saw on that previous slide with regards to chronic disease. It's estimated that about 80% of chronic disease is preventable just with the proper lifestyle behaviors. Unfortunately, though, we have a long way to go. About 5% of Americans participate in 30 minutes of physical activity each day. Fewer than 1 in 10 adults eat the recommended amount of fruits and vegetables each day. About 1 in 6 Americans currently smokes or uses chewless tobacco. The bad news on the smoking statistic is that we saw a little drop for a bit in smoking statistics, and now with smokeless tobacco, such as vapes, this statistic is going up actually, especially in our younger population. And greater than 30% of Americans report getting less than 7 hours of sleep per night, leaving our bodies prone to injury through a lack of recovery and general state of inflammation. Lastly, we're right now in being part of this this COVID epidemic, and I know that I'm speaking to individuals in the greater New York area where you may have been affected more than most areas. Certainly in Seattle, we've been feeling the pains of this too, but right now we're in an unprecedented time of social isolation. And we're really struggling to deal with the relationships and maintain relationships that really matter to us to keep us healthy. So while it sounds as easy as why don't we eat a little bit better or why don't we exercise a little bit more, we have to recognize the state that we're in right now. And the tough news is that we have a long ways to go. We'd think then, kind of just based on that information, that medicine would be doing something about this, and that our medical providers across the United States would be banding together to fight the good fight of treating and preventing chronic disease. what I want to do briefly is describe what is the current medical approach to treating chronic disease, and it flows as outlined on this slide in most cases. And I don't want to generalize this to be all physicians. There are some excellent physicians out there doing great work, making awesome pathways to preventive services. But the status quo right now is that if we're lucky, a physician will recommend lifestyle change. If a patient is diagnosed with type 2 diabetes, is given a diagnosis of heart disease, is found to have some kind of vascular issue that might point to needing a lifestyle change, even having high blood pressure, a physician will say, hey, you should go exercise more, or hey, consider this diet. And that's about as far as a physician can go. It's actually often not their own fault that that's the case. But that's typically as far as the physician's able to recommend. If it's indicated, medications will be prescribed specific to their metabolic risk factors. If a patient has high cholesterol, being put on a statin is very commonly the first line of defense, especially if a patient reports exercising already. Invasive procedures are done if necessary. If patients reporting that they've tried everything they can to lose weight, weight loss surgeries may be indicated. Certainly cardiac stents and other invasive procedures for heart disease, and certainly other things that can be invasive are done when chronic disease goes to the case that is needed. But generally, as part of medicine, there's typically no follow-up or specialty care unless a patient is significantly ill or injured. So treating chronic disease in medicine typically is that whenever you show up to your doctor, they'll give you a recommendation, but there's no system in place to help people with this kind of thing. If you've already encountered a, say, heart attack or a major cardiac event, there are programs such as cardiac rehab that if you're lucky to live in an area that has cardiac rehab at a hospital, you might be referred to something like that. But currently right now, it is not a reimbursable service to do preventive exercise. And as such, physicians typically do not refer to those programs, and those programs typically do not exist in medical systems. So we get that one and done encounter where a physician makes a recommendation and people go on their way, often not making the change that we know is needed. So I've talked a lot about chronic disease. I started my presentation on what a physical therapist is, and this is where I want to bring those two things together, because I think in medicine, for all of our medical providers across all settings, the biggest fight that we're all fighting right now is chronic disease. And I want to start with this message that with regards to chronic disease, physical therapists can make a difference. And the big place that they can start to make a difference is by addressing chronic disease and lifestyle through recognizing its role in the etiology and pathology of injury and pain. What I want physical therapists to take ownership of, and whether it happens now or more evidence is needed, but eventually at some point, we're all going to accept that the fact is that we have to treat chronic disease in order to treat the patients that present to us for injury and pain. There is a role in chronic disease for causing musculoskeletal injury and pain. So I'm going to show some studies here. This first study done by Collins and some of his friends on obesity, metabolic syndrome, and musculoskeletal disease, and trying to tie common inflammatory pathways to suggest a central role for muscle integrity. One of the highlights that I take away from this study is that impaired muscle integrity is a hallmark of metabolic dysfunction. In fact, many common inflammatory pathways have been implicated in the pathogenesis or the creation of interrelated tissues of the musculoskeletal system. Essentially, that's common inflammatory pathways that exist throughout the body, not just inflammation in muscles and joints, but inflammation that can occur systemically is related to musculoskeletal injuries such as tendinopathy, osteoporosis, and osteoarthritis. Despite these similarities, these diseases are rarely evaluated in a comprehensive manner. As I was suggesting before, when we see a broken body part like a torn rotator cuff or a sprained ankle or any number of issues that may be a bit related to chronic breakdown, we still look at people as broken shoulders, broken ankles, and broken backs. So with regards to musculoskeletal injury and tissue environment, there's a few things that I want to talk about and slides that I want to show that help to reinforce the point that chronic disease has an impact on muscle and joint injury. So with metabolic dysfunction, we have adipose cell infiltration within and between our muscle cells. So a hallmark of aging, frankly, and sometimes premature aging is that fat starts to deposit itself between our muscle cells. And what happens in these cases is that actually a number of cascading pathways get affected, which I'll talk about in a little bit. But if you look at the cell to the left, you can see that all those muscle fibers are aligned nice and straight and ready to contract in a way that would be unified to help a muscle move and a joint move. And if you look on the right, you see that fat has kind of pushed those muscle cells in different directions, which actually, when it comes to contracting our muscle cells, affects the way that those muscle cells effectively contract to move a joint. It realigns our muscle fibers to be inefficient and also replaces muscle with adipose tissue, meaning that there's less muscle to actually do the work. So just the mechanical function of muscle contracting is affected by the adipose cell infiltration within and between our cells. With chronic inflammation, in particular related to an excess adipose tissue or people being in that obese category, there becomes this imbalance of enzymes that we'll call matrix metalloproteinases or MMPs, which leads to a breakdown of the collagen structure of muscle, tendon, cartilage, and bone. So in a state of chronic inflammation, in particular in a state of chronic inflammation that's created through extra adipose tissue in the body, we have this imbalance of enzymes that occurs that leads to the breakdown of the stuff that makes up our musculoskeletal system. This really means that from the inside out, our muscles and tendons and cartilage and bone are getting broken down just as a result of chronic inflammation. Another thing that happens with chronic inflammation is that those cytokines, those inflammatory markers that are secreted from adipose tissue, reduce our stem cells, which sit within our muscle cells, within our muscles. So these stem cells typically activate themselves into muscle. So the life of a satellite cell is that it's supposed to, when activated, turn into muscle. However, in the presence of a lot of these inflammatory markers from adipose tissue, we end up having this stem cell turn into fat tissue instead of muscle tissue, which in the end leads to reduced skeletal muscle regeneration or a greater speed of breakdown than buildup of our muscle tissue, essentially that we can't keep up with the breakdown because all of our stem cells are turning into fat instead of muscle. Lastly, and while there are many of these, I wanted to cover the ones that I thought were most important, diabetes and vascular disease and its impact on musculoskeletal injury. So with insulin resistance and hyperglycemia, our blood vessels start to harden, and the ability for our blood vessels to deliver oxygen and perform the nutrient exchange with vascularized tissue becomes depleted. Just the basic not having as good access to red blood cells leads us to a worsened condition of our muscles, bones, joints, tendons, etc. So there's this big picture of things, and it goes well beyond what I'm pointing out today, that can cause orthopedic conditions just from the state that our body's in. And I want to summarize a few common orthopedic conditions because I'm talking a lot about these ideas of the state of our body, but I haven't used the terminology that you're probably used to hearing for orthopedic conditions. So I wanted to summarize a list of common orthopedic conditions that are either caused by or correlated to metabolic dysfunction and chronic inflammation. We know that more or less osteoarthritis is an inflammatory process that is caused by metabolic disease. What we don't know yet through research is whether the rest of these are actually caused by metabolic dysfunction, but we can say pretty sure that there's good correlation to metabolic dysfunction within these orthopedic conditions. So frozen shoulder or adhesive capsulitis, chronic and acute rotator cuff tears, and there's a number of lifestyle disorders that, or excuse me, lifestyle behaviors that are associated with rotator cuff tears. Carpal tunnel syndrome, which is significantly more prevalent in individuals with type 2 diabetes than it is in the control population. Plantar fasciitis, any tendinitis or tendinosis or inflammation of our tendons has a tie to chronic inflammation throughout the rest of the body. Osteoporosis and osteopenia, Dupuytren's contracture, chronic pain, specifically low back pain, is tied to, but not yet in a place where we can say that it's caused by metabolic dysfunction. And then any acute injury in the presence of metabolic dysfunction should be considered to be part of that process. Again, without knowing exactly for sure whether that metabolic dysfunction led to the acute injury, and there are some cases where we know that that's not the case. Just being in the state of metabolic dysfunction and breakdown in our bodies leads us to be more prone to tissue injury, and therefore should be considered with any of these conditions. If you look at this list and think about what physical therapists see, this is most of it. There's very few things on here that aren't on here that are within the physical therapist scope. Certainly post-op is treating many of these things. So this really is most of what our work is. And we just need to accept that metabolic dysfunction and chronic inflammation, that chronic disease, is contributing to the reason that people come to see us. Chronic pain is a little bit more complex and probably beyond the scope of this presentation today. In a survey of over 1 million people surveyed in the United States, there was a linear increase of chronic pain cases as BMI increased. So we have some good evidence to show that obesity is related to pain. We can't say exactly why that's the case, but as people increase in their obese status, the odds ratio of experiencing pain increased substantially in that 60 to 69-year-old range. And in females, people in the obese class 3 range were 4 times more likely to experience pain than those in the control group. So there is a tie between chronic metabolic disease and pain. Again, probably a little bit beyond the scope of what our conversation is meant to be today. So the other thing that I really want physical therapists, anyone who's thinking about becoming a physical therapist here, if there's, I hope, physical therapists out in the crowd that are listening to this, PTs can make a difference in chronic disease, again, by just recognizing the role of chronic disease in the creation of injury and pain for the people that we see. So we just have to see through the lens that people are coming to us for those issues. But physical therapists can go beyond that. Once we've recognized that that injury and pain is related to chronic disease, we can do some things to help be a part of the solution. In particular, to start with, using motivational interviewing to understand the desires and beliefs that drive change. Not looking at people as the result of a particular injury, but as a result of themselves, understanding what motivates them and helping people move towards positive lifestyle change. Using the pain and disability that people come to us with as motivating factors to catalyze behavior change. Not just accepting that we're going to try to fix people within a 6 to, let's say, 15 visit, if we're very lucky, time frame, but knowing that likely the pain and disability that people present to us with is part of that bigger picture that's going to take a long time, and that people can adopt lifestyle behavior change as a result of the reason that they come to see us. We need to take responsibility for assessing readiness and confidence to make changes in lifestyle behavior, especially with movement and exercise. And we have to commit to making a plan that includes long-term behavior change and includes other members of the medical team. So you might be thinking, is this just this crazy young guy's idea from physical therapy? Is this just him, some yuppie in Seattle that's just saying this stuff because that's what they believe up there? And luckily for me, the answer is it's not just me. The APTA for the last 10 years or so has been trying to promote our role in health promotion and wellness, stating that physical therapists play a unique role in society in prevention, wellness, fitness, health promotion, and management of disease and disability by serving as a dynamic bridge between health and health services delivery for individuals and populations. This means that although physical therapists are experts in rehabilitation and habilitation, they also have the expertise and the opportunity to help individuals and populations improve overall health and prevent the need for avoidable healthcare services. We need to be part of that bigger picture of health. In the Physical Therapy Journal, Janet Besner back in 2015 wrote that physical therapists are in an ideal position to promote health and wellness in their patients and clients. PTs can reduce risk factors and prevent and treat non-communicable disease by providing patient and client education, prescribing physical activity and exercise beyond, and what I need to insert here is beyond just the home exercise plan that's meant to, quote, fix pain, prescribing physical activity and exercise, and performing non-invasive hands-on interventions consistent with a biopsychosocial paradigm. Lastly, that physical therapists must accept, embrace, and act on their role in primary prevention to first assess and then discuss healthy behaviors with patients and clients, and provide education about the connection between behaviors such as physical activity and smoking and health. This is what the APTA has been saying for too long for us not to adopt this change. It's time for us to get in line and start to do something about that. So I'm going to get off my soapbox here for a minute on physical therapy because I know that I'm talking to fitness professionals and I want to take some time to make this as relevant as I possibly can to you guys. So why should you, the exercise community, care about physical therapy and what we have to say and what we might be able to do with regards to treating chronic disease? First, there's over 18,000 outpatient physical therapy clinics in the United States, where a majority of the current workforce of about 233,000 physical therapists work. We are a large profession. Physical therapists have established referral pathways with other medical providers and often represent the end of the road in medical intervention. When people get done with us, they often finish their medical care and don't seek care until the next time that they get hurt or sick, which means that if people stop with us, what could happen afterwards? And this is where we postulate that exercise might be a good continuation. PT often lasts just long enough to catalyze a behavior change, but not long enough to make behavior stick. The average physical therapy plan of care in the United States is about 6 to 10 visits right now, which means that we have 6 to 10 opportunities, if we're lucky, to convince people to adopt behavior change. If we are the providers that are starting to say, hey, we need to consider making changes in movement, in exercise behavior, in smoking, we get to see them just long enough to start behavior change, but not long enough to help them become accountable through that action and maintenance phase of behavior change. If PTs can commit to a role in treating and preventing chronic disease, then my belief is that PTs and exercise professionals, fitness professionals are meant to be. Because of all those things that I just listed before, we have some weaknesses in our profession that we need help. We need another provider to be that intuitive connection, and physical therapy and exercise professionals are that connection, in my opinion. We have common knowledge and goals around exercise and prescribe exercise to our patients, maybe in different ways, but in ways that could be more congruent if we work together. We both ask our patients for goals related to their lifestyles and their overall health, and we help people achieve their goals through the means for exercise. We teach people to train for their life, to get them back to their function and improve the function based on where they were at before. We, as physical therapists and exercise professionals, care a lot about biomechanics and form. And we're both good at cueing that stuff and can make common language and speak to each other in a way that can help build trust more quickly than we might be able to with other medical professionals. And lastly, our goal is to improve the function of our patients. This connection to me makes so much sense, and it fills the need of what I believe physical therapy and exercise professionals need to function better in a medical fitness setting. Our PT role typically is rehabilitation from injury and surgery or pain, getting people started with exercise and movement as part of the healing process, and then educating on the benefits of exercise. Occasionally doing injury prevention if we're lucky, but we often don't have time to do that. The exercise specialist's typical role is designing and implementing exercise programs and educating on the benefits of exercise. Imagine the power of us working together and building a bridge between physical therapy and exercise that allows people to continue exercise that they started in physical therapy and do so in a way that helps them continue to benefit from exercise as if it is a medicine to help prevent and treat chronic disease. If we had this pathway existing right now, there would be many, many people who would be in better health. I believe that what medicine truly needs is prescribed exercise. We do not create pathways to exercise professionals as medical providers, and we know the benefits of exercise on physical health are tremendous. I don't need to go down this road too long, and I think hopefully Jeff is going to help fill in the blanks a little bit on this for me. But the benefits of exercise on physical health are massive. And are barely summed up by this graphic here that shows reduced cardiovascular disease and strengthening bones and reducing risk of diabetes and controlling weight and cognitive decline and dementia, improving energy and improving sleep. What we really need in medicine to replace the medications, ideally if we could, is prescribed exercise that helps people start and maintain exercise behavior change. And we know that when exercise is prescribed, it can be so effective that it should be considered a drug. I love this article written by the British Journal of Pharmacology because they state that from a pharmacology journal, the people that are thinking about creating medications, that exercise is so effective that it should be considered a drug, but that more attention should be paid to the dosing and individual variations with it, between patients. As with many drugs, dosing is extremely important to get the beneficial effects of exercise. And I know that as a physical therapist, when I discharge a patient from my care, they go out and exercise by doing whatever it is that they know. And most people have no idea how to even start exercise. If I had a skilled medical professional or fitness professional to discharge my patients to, that I could trust was helping my patients dose and pay attention to the individual variations for their conditions, I would feel so much better about my patients' outlook on their health to start exercise. So why aren't PTs referring to exercise specialists? And I recognize that I'm a little odd because I talk in the language of optimism and a vision where we're already living in a world where we're connecting with each other. But the fact is that we don't. There are very few established pathways for PTs referring to exercise specialists. And in my opinion, physical therapists are not referring to exercise specialists because we want to hold on to our biomedical lens and the long held value that we hold as the fix-it providers. We find a lot of satisfaction in being the person that can fix somebody's condition. And we get a lot of really positive word of mouth as being those people. There's inadequate education on exercise, behavior change, and chronic disease in physical therapy programs. Flat out, exercise prescription is inconsistently done in a way that would be thorough enough for physical therapists to really leave PT school and be skilled. Exercise as an undergraduate education component is not required for entry into physical therapy programs, and behavior change typically is really just taught as theory in school and not often modeled by physical therapists in practice during clinical rotations. Cross-discipline referral pathways are uncommon, so this just doesn't exist, and it's hard to get it started because we don't have communication and role norms that are well established. We don't have good technology or methods to communicate between exercise professionals and fitness professionals that are in different settings. There's generally, unfortunately, a lack of trust in fitness professionals. We, as I think a community of medical professionals, want to believe that most trainers are doing good work, but we also hear a lot of the rumors of the weekend certified personal trainer, and we just want to know that the people that we're going to refer to are people that we can trust. And lastly, there's this interesting phenomenon, particularly in physical therapy, where we have these physical therapy aides or techs, which are care extenders, that sometimes we call these providers exercise specialists. Unfortunately, that terminology, I think, is confusing for physical therapists who already view exercise specialists as those aides and techs and not as a separate, important individual medical practitioner who has a role in preventing and treating lifestyle disease and could be a great bridge for physical therapists. So something I want you guys to walk away with is the ability to spot PTs that might get it. So this would be kind of my keys for looking and seeing a PT that might be a good candidate to collaborate with. So if you see a PT that believes the physical therapist role goes beyond fixing people, that might be a really good person to start collaborating with. If you see someone who's using language that doesn't sound like "I will fix you in this predictable period of time and that you will go back to your previous life," that's a good PT to start collaborating with from the exercise side, because they might view their role as going beyond just that episodic nature of care. Physical therapists that value exercise beyond rehab. People that exercise themselves will typically understand the benefits of exercise much better than others. Some physical therapists see exercise as a means to treat a condition, rather than a lifestyle that might help prevent and treat disease. And if you meet a physical therapist that walks the walk in terms of exercise and understands the value of exercise beyond the rehab process, that's someone who might be a really good candidate for collaboration. A physical therapist that asks questions to learn from you, seeks to understand your role in medicine. Someone who doesn't take and assume or take for granted that your role is to be a trainer that entertains people, but really asks you questions to learn from you, what you believe. These are the things that can help build connection. Physical therapists that are looking for ways to improve their practice, which is pretty common across our discipline, I would say. I think there's a strong culture of continuing education in physical therapy, but not often with regards to exercise. And then physical therapists that understand the challenges in the behavior change process, people that won't get upset if they refer someone to you and they don't stick with it, because we know that no matter how great our referred providers are, sometimes it's just really hard to start that behavior change of exercise. And it's okay that people won't adopt it right away. A physical therapist that understands that and is still willing to work with you, even through the failures and challenges that you experience in working with their patients, is someone who would be a really great candidate for collaboration with your care. For the exercise specialist, there's some things that you can do to gain the confidence of other medical professionals. Really just listen and tap into the needs of medical providers. Hear what they have to say about what they care about for their patients. And most of the time, it's customer service and trust. What they want is someone who will work with them and communicate. The other things are kind of bonus stuff. Actually, I'll say the next one isn't quite a bonus. Knowing how to safely work with individuals with comorbidities is a huge one. The fact that you're all here at an ACSM conference is fantastic, because this group has a really good certification program that can help you get prepared to work with individuals with comorbidities. And following ACSM recommendations is a great way to know that you're being safe with patients that might be coming from a medical setting. The other ones, though, are more of the bonus stuff. Working knowledge of basic anatomy and physiology is a great way to show a medical professional that you know what you're talking about and speak their language. If you know basic exercise progressions like the back of your hand, physical therapists will trust that you're going to take their patient who might be starting at a low level and be able to gradually introduce them to more challenging exercises in a safe way. Lastly, if you're able to track your data and show your results, you will stand out far above your peers, because you'll be able to show the impact that you're making on meaningful change with regards to exercise and behavior. I want to use this quote as kind of our summary and wrap up today from Eric Cressy, who states that providers refer to people before they refer to skill sets. It doesn't matter how good you are as a clinician or a trainer if nobody wants to deal with your ego, terrible bedside manner, lack of attention to detail, or just general poor attention to detail. And when we talk about collaboration in this case for collaborating with each other as physical therapists and exercise professionals to really fill this important gap that is the lack of exercise referral pathway in medicine, we just need to remember that providers refer to people, that you as people, if you can gain trust from medical providers, it really doesn't matter how good you are as a clinician or trainer if nobody wants to deal with your ego, bedside manner, or attention to detail issues. I can't agree with that more. As someone who gets to work in a pathway like this, I'll tell you the people that I'm most excited to work with are those that are paying attention to the things that we want to work on together, that listen to my patients, that show good service, and that are being safe. Thank you so much for taking some time to listen to me today. If you'd like to connect with me on LinkedIn, I've got a QR code that you can scan to find my profile, and I really enjoyed the chance speaking with you guys today. Jeff, take it from here, man.